Добрый день. It's nice to be back in Moscow. Boris, thanks for having me yet again. Always a pleasure coming here. Madam Chairman, board, dear audience. Today, I'm going to cover a subject which really will steer your outcome of the presbyopic refractive surgery. Some of the slides you might have seen before, some of them are new. I also like to point out the symbol up to your left. Denotes my university. That's the Ben Gurion University of the Negev in Israel. However, I work in Sweden, so I fly in between. Right. Let's start. Some general slides first. Prior to considering refractive surgery, there are some factors that you need to go through with the patient. The most important of them is realistic expectations. If the patient has too high expectations, well, you will never succeed. You will select the exact procedure for that person. Also, discuss the risks versus the benefits when you perform. Is there a potential enhancement? Can we do an enhancement? Are there alternative corrections, like spectacles, contact lenses, or other surgical procedures? All these things you have to go through with the patients. You need to be aware that patients with unrealistic expectations are no good. You also have to go through their records and see if they have an excessive history of complaints about their glasses or contact lenses. Do they drive at night? Maybe they are happy wearing glasses. Do they have existing problems with night glare? Or do they have a significant ocular surface disease, the refractive tear film? The natural vision is related again to the environment where we live and work. Here are some of the environmental parameters. Distance is 30 to 50, might be your working distance, or above 2.5 meters, like a lorry driver or a bus driver. This you have to go through very, very carefully before you let the patient through to your pre-operative evaluation. You have to evaluate the following before even considering any surgical procedure. Is the refractive error stable? The patient must be 21 years or above, and above 40, of course, for presbyopia. Is there a cataract development going on? And in certain contact lenses, you will see a corneal warpage that you have to take into consideration if you're going to contemplate surface refractive surgery. Another important factor is to do your pachymetry. That's to measure the corneal thickness. You place two roads. One is that you have to compensate the intraocular pressure and take into account the corneal thickness, because that steers to a certain degree the IOP. Also, your cornea must not be too thin if you are going to do a surface ablation. You must calculate to see that you have at least 410 or 420 microns left, including the flap, after the ablation. And the ablation depth, if you don't know it, is based on the optical zone, diameter, blend zone, and the refractive error. Pupil diameter, as I said yesterday, do play an important role because the larger the pupil, the higher the risk of high-order aberrations and might be manifest as poor night vision. So you have to measure your pupils both under photopic and sclerotopic conditions and document also for deep illumination. Warning, the alarm bells are going. This is a must because the refractive tear film plays an even more important role than we have thought. So what you do is to check your topography both in wet and dry stage. Look at this picture. This is just after blink. And if you look up, you see some red stuff, some red marks. Luckily, we were observant of this because this was a keratoconus. This is about after 15 seconds after blink. So you see the difference between the two topographies. Just after blink and about 10 to 15 seconds after. Always check this. It will also give you an indication, if you look at your SIM case in the diopters, how much the true refractive tear film really is. We do, of course, fundus examination on all our patients with this very elegant looking apparatus. You have to do manifest cyclopedic refraction. If you use wavefront, you don't need to use cyclo because the wavefront will adjust eventually after 3 or 4 measurements. Then it will adjust to the correct refraction. So you might like to skip this because the more drops you put into the eye, the worse it gets. Think about that. The color test is a necessity. Has to be performed to rule out strabismus, since patients with intermittent strabismus may not tolerate monovision corrections. The tear film assessment, again neglected by many, because this is where you might have the answers why the outcome did not turn out so good. A significant dry eye may delay healing and decrease visual acuity or visual quality during the early healing. A reduced tear quantity you have to note down, and I will show you in a sec how you do that. Also, with corneal stainings, we use lissamine green and fluorescein stains. And for the conjunctival staining and the tear prism height, we use lissamine green. What we do with all our patients, irrespective, is to give them wet tissues for cleaning the eyelids. So we rule out blepharitis and meningitis. We also give them artificial tears before surgery. Serves 2 purposes. A, will improve the tear film. B, the patient is getting used to take eye drops. So it's very good. The phenol red thread we use extensively now. We moved away from the Schirmer test. Schirmer takes too long. This only takes about 15 seconds. And it's, you know, pretty good reliability with good repeatability. Very easy to perform and not so irritating for the eye. The tear breakup time, you can do it both invasively and non-invasively. The non-invasive way is to use either your keratometer or your topographer, ask the patient to blink, stop blinking, and take the time until you see the Myers go through it. Or the invasive method is to check it with the fluorescein. Tear break-up time of less than 12 to 15 seconds should be noted. This amine green is a much better stain than rose bengal because it's less irritating. And it picks up very, very quickly. Serves two purposes. You can see any damaged cells or dead cells, and you can see the tear prism height very, very clearly with this stain. Very effective. Of course, I don't need to go through this. You have to do a good slit lamp examination for your patients. Again, look at, particularly on the eyelids, because the blepharitis and the myodermitis will steer the tear film. There might be presence of staphylococcal bacteria in these conditions, and that is, of course, increasing the risk of infection during surgery. Intrastromal scars may result in an irregular ablation rate, and larger pinguate could make it difficult to get a proper suction of the keratome or for the femtosecond laser docking. Another important thing is to measure and monitor the IOP. So the IOP you have to note down together with the central corneal thickness and compensate for the IOP, for the central thickness. You also do baseline optic nerve or nerve fiber layer imaging. Might consider doing visual field studies and baseline cranioscopy. You have to emphasize for your patients, if we are again doing surface ablations, that it's a lifetime long follow-up of these patients, at least to monitor the IOP. The assessment of optical quality, we do have vision for you using our wavefront, and it will tell us immediately how good or how bad the outcome will be. You have to bear in mind that the higher order aberrations are thought to contribute to over 20% of the total number of aberrations in a normal eye, and may contribute to even higher percentages in eyes with diseases such as keratoconus and those who have undergone previous surgery. So this is how we do it at Vision for You in Lund in Sweden before even considering the patient for a surgical procedure, whatever that might be. Thank you very much for your kind attention and have a good day.
Thank you, Dr. Claes. It's said that